Eko, and good evening. I am Dr. Madiha Batool, and I'm a consultant gynecologist, and I'm a COT mentor as well. And today's speaker for today's discussion. So I will um, I will welcome you all, and I would like to thank you in advance for your interest in this topic. Um, I hope that what I am about to teach you will be interesting and informative and will help you in clarifying your concepts. I congratulate all of you as you have taken an initiative to give the part two, and now you are demonstrating your commitments for preparing the exam. And I must tell you, this is one of the toughest exams and may your hard work repay you in success. And my team, the medicine tutors, they are making efforts to make this path easier for you, and you may carve out your path to success. I want to thank my team as well. They have given me the opportunity to being a part of this wonderful team, and they have taken a very good initiative to guide all of you to go through the exam preparation. So today's topic is nausea and vomiting in pregnancy, which is one of the Green Top guidelines. So Green Top guideline, we all know that it is a worldwide guideline. They took recommendations from all over the world. They took data from all over the world, and then they tried to make some changes in the management of the problem. So before we start, we all know that whatever we do, where we do hard work, whatever kind of like energies we are putting into find the success, there is no secret to success. It is a result of your preparation. It is a result of your hard work and learning from your failure. So whenever is it during failure, then you will get the more chance to develop more skills to go through the exam and get more time to prepare yourself. So failure is not something that can stop you to clear this exam. Okay. So a dream doesn't become reality through magic. It takes sweet determination and hard work. So hard work is a key to success. You have to work day and night. You have to work together in the groups to find your success path. So nausea and vomiting in pregnancy. Nausea and vomiting in pregnancy is defined as the symptoms of nausea and vomiting during pregnancy when onset is prior to 16 weeks of gestation and where there are no other causes. So there are two parts of the definition. The first part states that this is the onset of the vomiting and it is prior to 16 weeks. You know that prior school of thoughts, they usually say that nausea and vomiting is the thing that comes prior to the 12 weeks of gestation and it usually resolves around 12 weeks or after 12 weeks. But now they have changed the dimensions and previously they have called it as morning sickness. But nowadays, in the new guideline, they have totally explained that this morning sickness is not the word for the nausea and vomiting pregnancy because it is not occurring in the morning. It is occurring in the noon. It can occur in the evening as well. So nausea and vomiting prior to 16 weeks of gestation with no other causes. So you have to exclude all possible causes of nausea and vomiting. Then hyperemesis brevidorum is diagnosed when the symptoms start in early pregnancy and it is a severe form which is affecting the daily life activities with the signs of dehydration. Then the incidences that are present in this guideline, the overall incidence is 90%. The nausea and vomiting in pregnancy, it affects overall 90% of the population. So 9 out of 10 patients will have it. And then comes the hyperemesis brevidorum. The incidence is 0.3 to 3.6%, and the recurrence risk is 15.2%, and the self-reported cases are 89%. Only 10% with hyperemesis gravidarum need termination of pregnancy. And then 9.14% need admission. The peak problem or the peak symptoms are at 9 weeks, and 90% resolve at 20 weeks of gestation, within 20 weeks of gestation. So two-thirds have the abnormal thyroid dysfunction, and 40% have the abnormal liver function test. SMT is the subcutaneous metoclopramide treatment, and it is effective up to 89.3% of the cases. So these are the incidences that are being discussed in this guideline. So before going towards the main cause, what is the etiology behind this pathology, we have to go with the recommendations that are given in this guideline. So as per the recommendation of the guideline, an objective validated index of the nausea and vomiting, such as pregnancy unique quantification of MSs, which is called QK, uh, and hyperemesis level prediction help. So, help and QK, these are the two validated index that has been used to quantify the problem of nausea and vomiting in pregnancy. And these are the two. And this is been clearly given in the guideline. We will discuss each and every in very detail soon. So there is a safety and efficacy data for first line antiemetics. So we all know that for nausea and vomiting. So this whole guideline is about the treatment that are going to give, what kind of treatment is preferable, which kind is have more safety, and there are some differences in the safety profile of various medications. So this guideline is all about the medication. So you have to learn all the medications, what are the first line, what are the second line, what are the third line. They are already given in the previous guideline, but now they have given the more discussion about it. So, ketonuria is an indicator of dehydration. We all know that, but it should not be used to assess the severity of nausea and vomiting in pregnancy, because ketonuria is oftenly seen in the normal patient, those who even they don't have nausea and vomiting, but this indicator is seen in that. So this is no more an indicator of dehydration, and we all know that for hyperemesis gravidarum, we all know that that was a triad of three things. Once there is a 5% reduction in the weight loss, there is extensive vomiting, and there is ketonuria. If this triad was present, then the patient was diagnosed to be having hyperemesis gravidarum. But now they have shifted, the whole paradigm is shifted. Now they have just they are stating that hyperemesis gravidarum is not like we should not have to quantify the thing that whether there is 5% weight loss or not there, or is there any excessive vomiting. Any vomiting which is severe, any vomiting that is affecting the life of the patient, and she is not able to drink, and she is not able to eat, and she is not able to do the routine work with the signs of dehydrations, then it is called hyperemesis gravidarum. There is no need to quantify the trial. So any subjective thing that this patient telling you about, you have to rely on it. Then the efficacy data. So there is a discussion on antihistamines, phenothiazine, doxylamine pyridoxine, which is called Zombia, and they should be prescribed initially when required. So this is the first line. Then comes the ondansetron, which is safe and effective, and it is second. It is used in the second line. And it should not be discouraged if the first line anti-methods are ineffective. And there is a whole discussion on this ondansetron in the guideline, that how effective it is in controlling the nausea and vomiting. Women can be reassured regarding a very small increase in the absolute risk of orofacial clefting with the ondansetron using the first trimester, which should be balanced with the risk of poorly managed hyperemesis gravidarum. So what we are saying that initially it was proposed, or it was seen that ondansetron was associated with the orofacial septic. And due to this side effect, this food was it was deferred in the early trimesters. But now they have seen that they have weighed against the poorly managed hyperemesis gravidarum. So they say that if the hyperemesis gravidarum is managed with ondansetron, the patient should be explained that the risk is minimal and the use of the drug is safe. Then come the safety of metoclopramide, and it is also safe and effective and can be used alone or in combination with the other antibiotics. But we all know that what are the side effects of metoclopramide. Metoclopramide is associated with extrapyramidal effects, and so that is why it is the second line therapy. So whenever we are going to give it, we have to explain all the effects to the patient, and if we are going to give the injections, then it should not be rapid one, and we should have to minimize the speed of the injection for at least 2 minutes. And women should be asked about the previous adverse effects of the antiemetics therapies, and if there is any, suppose if the patient is allergic to ondansetron and we are going to give her ondansetron, then this allergic reaction might be crucial for her. So we have to explain the patient that we have to take a brief history from the patient before prescribing any medications to her. Then comes the normal saline, which is 0.9%, with addition of potassium chloride in each bag. And this is the ideal solution, which has a balanced electrolyte, and it is most appropriate for IV hydration for these patients. Then come the single use or the combination of drugs. So there is a whole discussion, almost 60% of guideline is filled with all this discussion. You have to go and you have to read yourself that what kind of combinations that they have like explained. So if one medication is not effective, then we have to add in the other medication, like the two or more. And if even we can go up to three medications, and even if they won't work, then we have to go with the ambulatory treatment in the form of injectables. Then comes the discussion on a thiamine supplementation, which is good, and thiamine supplementation should be given to all women when they are admitted for the vomiting, or they have reduced their intake, and especially if we are going to give her parenteral nutrition or dextrose. Because if we give some dextrose, there is the precipitation of symptoms of Wernicke's encephalopathy. So Febrinix is an ideal solution which contains all these things, and we can add 100 milligram of it into the fluid. Then comes the therapeutic, if all the therapeutic measures are failed, then termination of pregnancy can be seen. So, who is the culprit behind the problem? So, what was the previous school of thought is that it is HCG, but now it is not HCG, it is GDP15. GDP15 is a polypeptide hormone which is secreted from the fetal side of the placenta. And what this hormone is doing, this hormone is causing excessive nausea and vomiting. And those women who are more sensitive to nausea and vomiting, the levels of GDP were found very high, and especially those who was admitted in the level of GDS 15 was found higher in the patient with hyperemesis gravidarum. So now the whole paradigm is changed. That it is not the HCG trigger that is causing the nausea and vomiting. So there is some familiar disposition of the same. So once the patient is get pregnant, then the formation of these proteins are more. So some women they have lesser quantity of DTP, so they have lesser symptoms, and some may produce more quantities of DDT and may lead to more symptoms of nausea and vomiting in pregnancy. And even in severe cases, and sometimes you can see that nausea, the recurrence rate is high. If in the first pregnancy, they are producing higher quantities of GDP, then in the subsequent pregnancy, there are chances that they will suffer with the same problem. So now the culprit is it's not HG, it's DDP. Okay, so it is produced by the placenta, and when genes are activated during pregnancy, its level are also influenced by the mother's sensitivity to the hormone. So the major mechanism which is recently being elucidated is the hypersensitivity to the vomiting hormone, which is called growth differentiation factor 15. So this higher circulating factor, it's not ECG that is found in the hospitalized patient, I was telling you, and it is most likely the positive agent. Then comes the hyperemesis gravidorum. The recurrence is really high. I told you it's about from starting from 15.2% to 89%. So what is the definition of hyperemesis gravidorum? Hyperemesis gravidorum can be diagnosed when symptoms start early in the pregnancy, and nausea and vomiting is so severe enough that it can cause inability to eat and drink normally and strongly limit the daily activities of living. So here you can see there is no triad of weight loss and proteinuria, and but there are the symptoms of heavy or severe vomiting that are present, and the symptoms they begin very earlier. Okay, so the peak time is basically it starts at the 4 weeks of gestation. So this is the overall incidence diagnosis. Again, I told you at least 5 to 16 more weeks of gestation, and we have to exclude all the causes of vomiting. I will tell you in the history taking that how we are going to take the history of these patients. So again, this is important. Inability to eat and drink normally and do the daily living activities with the signs of dehydration are contributing to diagnosis. So with no need to quantify, once patient is saying you have to rely on the patient symptoms. So this is the graph. This is telling you that the symptoms usually start from the fourth weeks of gestation, and this is how it feels, and then it comes down to the baseline around 17 weeks of gestation, and it resolves in 90% of cases by the 20th weeks of gestation. So again from the guideline, the definition represents a shift from historic reliance on objective measurements. So that I was telling you that previously we have to quantify the weight loss and electrolyte imbalance, and now the whole paradigm shift towards the subjective patient focused criteria, and now we are able to recognize more and more cases of hyperemesis gravidarum. So this is the international definition, which is Windsor definition of hyperemesis gravidarum. Here we have to shift from objective to subjective measures. So how should women with nausea and vomiting and hyperemesis gravidarum be cared for? So we all know that these are the symptoms: extreme thirst, dry mouth, swollen tongue, less frequency of urine, often headaches, fatigue, bad breath, palpitations. So tiredness, these all the symptoms. And we have to quantify with the score, which is called the Puke score. And according to the Puke score, we will quantify it as a mild, moderate, and severe. So this is the Puke score. Here you can see this is the score of the replies of the questions. And these are the three questions. These are the basically three questions. In first question, you can see that the times is asked. The time is asked. Like in last 24 hours, this scale is validated for 24 hours. So in last 24 hours, how many times you have felt nauseated or sick to your stomach? And here you can see the score is from 1 to 5. And these are three files, marks, 2, and 3, which is make score of total of 15. So here, now we are able to diagnose that the severity is either mild which is up to 6, or it can be moderate, which is up to 7, or 7 to 12, or it can be severe from 13 to 15. So the PUK score is a validated score to objectively assess the severity of nausea and vomiting and the treatment response for mild to moderate conditions, not for the severe. For the severe condition, we have another validated score system, which is called a HELP scoring. So here you have to memorize these three questions. That in last 24 hours, this is for the feeling of nausea. Second question is the episodes of vomiting, and the third question is about the episodes of retching and dryness. So here you can see if she's having if she's having feeling nauseated for more than 6 hours a day for past 24 hours, and she has been vomiting up to 7 to more episodes in the last 24 hours, and she is feeling retching or even dry hiccups, then this is the score of 15. And here we have to see the patient is going into hyperemesis gravidorum, which is the more dangerous condition. So nausea and vomiting is the most common one. So here you have to score how many hours you slept out of 24 hours. So if she is not even sleeping and she is vomiting all the time and even her sleep is disturbed, then her well-being will be disturbed. On scale of 0 to 10, how would you rate your well-being? This thing is very important. And here we have to incorporate the depression question as well. The holy questions. I think I have explained in my previous lecture. What are those questions? Can anybody tell? Because a mental distress is the more common thing that is happening with the nausea and vomiting. So we have to uh, assess the mental state of the patient as well. And we will see in the charts, in the management charts. So what were those holy questions? Anyone can tell? Anyone from the audience? Yes, you can raise your hand, or even you can type in the chat. Those were very easy questions. I hope you have gone through the module. Okay. So I will ask the mm, I will ask administration to take answers from you, okay? And I'm moving on. So then next one is a health score. Health score is an other value score to determine the treatment plan. So here we have seen that what is the level of nausea, what are the episodes of vomiting, what is the itching, so what are the retching and dry heat, she's urinating or not, and what is the score after 1 hour after taking leave. So average number of hours she is unable to do work, problems in her job, she is feeling sick, whether she is in coping with her nausea and vomiting and retching or not, what is the total amount of eating and drinking she is able to, like here they have given the quantification as well, that how much meals and how much cups and how much fluids are being taken by her. So any medicines are given to her, and whether they are tolerated or not, whether the symptoms are being improved compared to the last week, whether in the last 7 days. Then comes, sorry for the interruption, I had a call. Then comes weight loss, and then number of treatments she has taken, and then we have to count the score. So on the basis of this score, here you can see the score, uh, 5 for each should be given, and here there is a mild, moderate, and severe. So for none to mild, it will be less than 19. The score of 20 to 32% So they will, in the question, in the exam, they will not ask you about the chart. They will give you the score that now the patient is having, she had a previous history of nausea and vomiting. Now the patient score is, the PUK score is like 12 and the health score is 2032. And she has been prescribed this and this medication. So what will be your plan of action? So what you will do? Okay, so they will ask the questions in this pattern. So for the severe, the values are between 33 and 60. We have to take the detailed history. History. So previous history of nausea and vomiting, we all know that it's a recurrent condition. We have to quantify the symptoms by applying either the QK or the health scoring, and then we have to see whether there is any weight loss, inability to tolerate the fluid, and inability to perform the daily activities. We have to ask about the nutrition status as well, or the rapid weight loss, and we have to ask about the comorbidities that is in the form of epilepsy, diabetes, HIV, the psychiatric condition, and hypoadrenalism. Then the relevant surgical history, we all know that there is a huge discussion on the gastric bypass, and majority of the patients, those who are morbidly obese, they have undergone these procedures, and they, although in the normal life they keep on having this problem of nausea and retching, and once they get pregnant, it becomes more severe. So here, the history is very important, and these patients are at risk, and we may have to admit these patients, and we have to go with the inpatient protocol. So history should exclude all these things. So the part of definition is we have to exclude all of the causes, and then abdominal pain, the urinary symptoms, infections, any drug or history of recreation drugs or chronic H. pylori infection. Then we have to examine the patient. We have to take the basic recordings in the form of temperature, heart rate, blood pressure, saturation, respiratory rate, abdominal examination, the weight of the patient. Then signs of dehydration in the form of sunken eyes, dry lips, mouth, oliguria and urea tachycardia and hypotension. Then the signs of malnutrition or rapid weight loss, which is more than 5% pre-pregnancy weight. This is not the pregnancy weight. This is of pre-pregnancy weight. It is also an important exam question. Okay. Then comes the muscle wasting, which should be measured by mid-arm circumference. And we all know that if we have studied previously that there was some disorders in which the patient with eating disorders, that patient is not eating prior to she prior, and she got pregnant with the same problem. So she will not be eating, and this problem will be aggravated. And so we have to see the muscle wasting, which is very important. That whether this patient is malnourished prior to the pregnancy, or she has developed these when wasting during the pregnancy. So then comes the neurological signs, which is important in the Wernicke encephalopathy, which is confusion, nystagmus, ataxia. So these are the problems which are present in the Wernicke encephalopathy. Then these are the examination points I've discussed. Then comes the investigation. So urine analysis for the nitrites may indicate the infection. So you all know that urine tract infection can cause the vomiting as well. So presence or absence of ketone urea in the pregnancy is not an indicator for dehydration. So we have to assess the urinary ketone, and it does not affect. It should not affect the management of the nausea and vomiting. So it can be misleading. So then comes the midstream urine. It is important to rule out the urinary tract infection. Then comes the urea and electrolyte. And the urea electrolyte measurement is very important, especially in those patients in which we have to start with the IV fluid management, like in the patient who are either ambulatory or in the inpatient. Majority in the cases of inpatient, where the patient is in receiving the wards. Then comes hypokalemia and hyperkalemia, which is very important. The electrolytes, because it can be abnormal, especially in those patients who have a chronic kidney disease. High creatinine urea can be due to the dehydration, and it can be due to the acute kidney injury. So it is very important. Then comes the full blood count to rule out any anemia, infection, hematocrit problems. So we have to do this. Then blood glucose levels to exclude diabetes. We have to exclude the diabetic ketoacidosis, especially in the patient who has type 1 diabetes. Then ultrasound is very important in those who are having refractory cases, those who are having excessive vomiting, intrauterine pregnancy, especially the multiple or trophoblastic disease should be ruled out. Then the infected cases with the frequent admission or with the previous admission, they should have a check on their thyroid function test. Either they may be hypothyroid. There is a discussion on thyroid function. We all know that the beta HCG has a unit which is similar to the TSH. So, thyroid stimulating hormone. So, these due to the similarity in the units. So, beta HCG might mimic like TSH and it might lead to the formation of more and more thyroxine, which can lead to the hyperthyroidism. And this hyperthyroidism it is important because if if the patient is not having any thyroid disorder prior to the pregnancy, and now during pregnancy due to excessive vomiting, and she's having palpitation and she's having sign of dehydration. So once we have done this test and we have found that her thyroxine T3, T4 they are raised, and TSH is normal or it is low, then we have to repeat these tests rather to start the treatment because we all know that the effect is due to pregnancy. So pregnancy-induced hyperthyroidism, it is rarely because of the thyroid antibody, so it is not a pathological condition. It is mostly physiological, and we have to just repeat the test after a few times. And if it is normal, then there is no need to give any kind of medication. So this is important. Then comes the liver function test, in which we have seen that hepatitis, gallstones, even malnutrition can be assessed, and we have seen that up to 40% of the cases we have delayed liver function tests, especially of hyperthyroidism gravidarum. Then the test of calcium and phosphate, then amylase. Yes, amylase is important, especially if the patient is having epigastric pain that is not recovering with your medication, and the patient is having excessive nausea and vomiting. So we have to exclude this test. And you will see in the subsequent charts that this investigation, especially MLAs, we are not going to perform in the daycare, especially in the GP clinic. So this test is more performed when we are going to decide about the admission of the patients in the inpatient facility. Then comes the venous blood gases, and it is important due to the presence of metabolic disturbances. So, what are the metabolic disturbances that we can see in here? This is transient hyperthyroidism, this condition is called THHG, transient hyperthyroidism of hyperemesis gravidarum. Okay, so these are the problems that can occur with the pregnancy: hyponatremia, hypokalemia, low serum urea, raised hematocrit, and sometimes ketonuria. This is the problem. Metabolic hypochloremic alkalosis. So this is an important exam question as well. So what is the metabolic disturbance that can occur in hyperemesis gravidarum? That is metabolic hypochloremic because she is losing her stomach acid. So this is metabolic hypochloremic alkalosis, and it's where metabolic acidosis may develop. Okay, in two-thirds of the women with hyperemesis gravidarum, there may be abnormal thyroid function test, which is based on the similarity between the thyroid stimulating hormone and HCG with a biochemical thyrotoxic process, and this rise in the thyroxine with or without suppressed thyroid stimulating hormone. So here we have seen that we have to just no need to give any treatment with antithyroid drugs. So a raised T4 and a low TSH therefore do not need treatment in the straightforward nausea and vomiting where the cause is clear. and the patient is respond to the treatment. Then comes the liver function test are normal up to 40% of the women, with most likely abnormality being the rise in the transaminases. This is also an important exam question. So level of both bilirubin and amylase may be mildly elevated. So hyponatremia, hypokalemia, low serum urea, raised hematocrit, ketonuria, and metabolic hypochloremic acidosis. And ketonuria should not be used as an indicator to assess the dehydration. Then comes the severe malnutrition, which can be assessed by the anthropometric measurements such as mid-upper arm circumference, and it is more useful. And we have to do the serial measurement. If we found anything below the marker, like if we found some malnutrition, so we have to repeat it. We have to take the serial measurement, and this is the validated, and this is month 4, which is called malnutrition universal screening tool called must. This must is an again an validated screening tool to identify malnutrition in such patients. There is ultrasound. We all know that why we are going to perform ultrasound, to rule out multiple pregnancy, to rule out the molar pregnancy. So this is again mild. We have to for mild cases we have to give the community care in the form of oral antiemetics. We have to reassure the patient. We have to give the oral hydration, dietary advice. If she is unable to tolerate oral antiemetics, then we have to give the ambulatory or the daycare management, in which we have to we have to provide her intravenous fluid with vitamin B1 and parenteral antiemetics. So these are the three domains. So remember, you in the nausea and vomiting, even though the guideline is very simple, so they can throw a very tricky question. They will give you the score, and so they can give you the score, and they will ask you the management. So these are the three streams of management. One is the community-based management. The second one is the ambulatory daycare management, which is an outpatient management. And the third one is the inpatient management, in which we have to keep the patient admitted. So, for the community, we all know that what is the system in the NHS. Patient usually report to the GP first, and GP takes the complete history, and he or she will decide the management plan for her. If she find any risk factor in the patient, and patient is having severe nausea and vomiting, so he or she will assess the signs and symptoms of dehydration, and it will be earlier consideration for the ambulatory treatment. And if the ambulatory treatment will not work for her, then the inpatient treatment will be given. Why inpatient treatment is at end? Inpatient treatment is a more vigorous treatment. And I think when I was teaching you the venous thromboembolism, what was the score for hyperemesis gravidorum? This is a very important question. You can just type in the chat what was the score of venous thromboembolism in hyperemesis gravidorum. Yes, please, audience, please do some mind storming and just answer me, because I've told everything in very detail, and I have given the scores even. So this inpatient, while I'm telling you, you have to write in the chat. So this inpatient treatment, I told you that whenever patient is routine, whenever we have admitted the patient, we have to do the venous thromboembolism scoring. VT is scoring at every aspect, at admission, during the stay, every day. Okay, and we have to calculate the requirement for Clexane or other antithrombotic treatments, or just hydration, or just mobilization. We have to decide the management plan. So whenever the patient is in or is admitted, we have to do the VT scoring. And if the patient is having hyperemesis gravidorum, the score is 3. Okay. And here we have to start with the click name. So we have to calculate, and this is the score just given to this condition. If we add the score with the other existing conditions like the patient obesity, like smoking, the score will again go up, and we have to calculate the. We have to involve the hematologist. We have to calculate the exact dose for again for this patient as well. Okay. So why we are doing this three streams of management just to because we all know that the 90% will present to you. So it's a duty of a GP who will stratify the patient for you, and well, the most important is the ambulatory care. Why? Because here from ambulatory care we have to decide the plan for we have to refer the patient back into the community if the symptoms are relieved. And if we find any comorbid or if we find any complication, we have to refer to the admission. Okay. So all three streams you should know very well. So these are the indications for the inpatient care. Inpatient care is considered at least one of the following. So one, two, three, four. 4 points. We have at least one of the following, then we have to do the inpatient. Continued nausea and vomiting and inability to keep down oral antibiotics, continued nausea and vomiting with clinical dehydration and uh, greater than 5% of weight loss despite of oral antibiotics. And here you can see oral antibiotics are not been tolerated. Confirmed or suspected comorbidities such as UTI or other like other problems. Then other comorbids like epilepsy, diabetes, HIV, hypoadrenalism or psychiatric disease. And here the patient is unable to maintain the oral hydration and medication. If woman is unable to tolerate oral antibiotics or oral fluids, then ambulatory daycare management. Okay, so in the ambulatory, what we are going to provide? We are just giving them IV fluids with B1 thiamine and parenteral antibiotics is preferred. Thiamine stored in a previously healthy individual can deplete rapidly and cause a symptom of tachycardia, weakness, and decreased tendon reflexes, which is within 1 week without intake. So ambulatory management in which we have to give the patient IV hydration and we have to stratify the patient into either back into the community or we have to give the inpatient. This is again the inpatient. So whenever the patient is admitted, ultrasound scan should be confirmed to see the viability, gestation age, multiple pregnancy, trophoblastic disease, and other medical condition that is where ultrasound is urgently required. So we all know that trophoblastic disease and multiple pregnancy can increase the risk of hyperemesis gravidorum. So what are the pharmacological therapies that are options available? So we can try the combination of different drugs which can be used either a single or delayed. In UK, the first line is the mostly doxylamine and pyridoxine with vitamin B6. It it were one of the like licensed drug which is most commonly used for mild to moderate cases. Then comes the if it won't work, then comes the parenteral or transdermal or rectal routes. If the oral regime is not working, then corticosteroids are usually reserved for the for those cases who are refractory to the treatment. So what are the antiemetics? So this is the line of antiemetics which you should memorize. In the first line, we have doxylamine and pyridoxine, and here you can see the dose is 20 by 20. So what are the preparations available over here in Pakistan as well? The dose is 10 by 10, and we can start with the 10 by 10 dose, and we can increase accordingly. Like we can give 10 at night and 10 in the morning. Then comes the cyclizine, which is 50 milligrams. Cyclizine is available in the market. I will not tell you the brand name. You have to search yourself. and you can even try 8 hour day. Those who cannot tolerate this, because this is antihistamine and it has like some side effects of sedation, and those who can't tolerate it, we can try another one like prochlorperazine, promethazine. So these are all that can be given either orally, either intramuscular or intravenous. Prochlorperazine, it can be buccal, and it can be given periphery as well. Then the second line. Second line have a more discussion. I memorized this second line as mode, MOD, like metoclopramide, ondansetron, and domperidone. So these are the three important medications which are present in the second line. Metoclopramide is very important and is very effective, but it has some extra parameter side effects, and even it can be given subcutaneously as well, which is an extra advantage. Then domperidone, which can be given 10 milligram, and even it can be given parenterally. Ondansetron 4 milligram, the dose is 8 hourly, or 8 milligram, the dose is 10 hourly. And for the IV, 8 milligram can be given over 15 minutes, 12 hourly, and 16 milligram daily per hectare. So these are the things that you need to memorize. One of the side effects with ondansetron is the constipation. For that, we need to give her laxatives as well. Then comes the third line, which is hydrocortisone, 100 mg twice daily given IV, and once clinically improved, then we have to convert to the prednisolone, 40 to 50 milligram per day, which is gradually tapered, and we have to maintain on the lowest dose, lowest possible dose. And what are the side effects if we are giving corticosteroid is that we all know that corticosteroids are associated with a decrease in the blood sugar levels. So we have to check the patient for the blood sugar levels. And the second thing is that if the patient is keep on using this corticohydrocortisone during pregnancy, we have to give her what? We have to give her some medication during labor as well. So this is your homework. You have to tell me later on that if the patient is given either IV hydrocortisone or prednisolone, that what are the things that should be kept in mind and what should be given in the label, which is an important exam question as well. So antihistamines are the first line and should be prescribed earlier, and they should be combined with the other antiemetics at the hospital start. So once the patient is admitted, patient is treated, and now we're going to start. So we have to give them again with the antihistamine, and it can be combined with the other like dopamine agonist, antagonist, and serotonin antagonist. So this is about the again corticosteroids, and here we have to give the extreme precaution. And there is one important discussion. It's a very interesting discussion about ginger tea. We all know that there are some things that are usually like you have to take this thing to relieve your symptoms. So these are the home remedies, and there are some things that are present over the counter, and this thing is very common all over the world. So some things are some chewy gum, some like hot drinks. They are available over the counter, and that are usually decided that this thing is associated with nausea and vomiting. In the previous guideline, even they have told that ginger tea is important in reducing your uh, symptoms. And believe you me, that we usually offer every patient with in pregnancy to have this ginger tea to relieve their symptoms, but practically it won't work. And even in the guideline, they told you that if you are going to say that, it might have reduced your scores. Like, matlab, if this thing is, if you are as a GP, if you are telling her to take the ginger tea, then the chances that the patient will not rely on you because she will say that this doctor is not of worth and she is telling me about the ginger tea, which is not even in some cases the symptoms can aggravate as well. So there is no role of ginger tea. So then there says discussion about the problems of the medication. Here, why metoclopramide is second line due to the extrapyramidal symptoms. Why extrapyramidal symptom is occurring, then how to minimize. These are the dystonic reactions which are present with this, and we have to minimize by the slow infusion. Okay, at least over 3 minutes with the help of pump. Then comes the woman should be asked about the previous adverse reactions. We have discussed this in this previously. Then comes the other additional medications that should be given. So, and what are the safety profiles? So, first line, why it is called first line? Because it is safe. So, it is safe to take in the first half of the pregnancy. In the second line, we all know that ondansetron can cause the midline orificial defects, and it should not be taken. But we have discussed about it that this thing now Nahra did not like warn us now, and you can use it safely. And even at the end of the guideline, they have given you one chart in which they have told you that how common the problem is present with online steroids. Data has confirmed that corticosteroid use in the first trimester is not associated with increased risk of congenital malformations. So now they are telling us about the safety of these products, these medications we are using. So overall and specifically, no increase in the orifice affecting cardiac defects or hypospadias following the first trimester use of corticosteroids. So what adverse effects can occur from nausea and vomiting and how they can be prevented? So we all know that these we have to have a look on urea and electrolytes, especially in those patients where we are going to give intravenous fluids. Then histamine like type 2 receptor blockers, like in the form of proton pump inhibitors, they should be given to the patient for the GERD or for hepatitis or for gastritis. So, it is usually recommended for the recurrent intractable vomiting and for gastroesophageal reflux disease. Thiamine supplementation, it minimizes the effect of IV fluid. We are giving more like in the form of dextrose. So, thiamine, if it is given, it can reduce the risk of Wernicke encephalopathy. Thiamine supplementation is very important, either oral, 100 milligrams CDS or intravenous as a part of the B-complex Fibrinix should be given to all the women admitted with the vomiting and it is with a severely reduced dietary intake and especially for those patients who we are going to give the dextrose in the parenteral nutrition. So ideal nutrition is 0.9% saline with added potassium chloride. So when all other medical therapies have failed insufficiently managed, so this is the last resort that we can do the parenteral treatment. So for parenteral treatment, we have to do the multidisciplinary routine. We have to involve the gastroenterologist and we have to continue the ongoing management. Around 10% of the women with hyperemesis gravidorum will terminate unwanted pregnancy and due to this condition, a self-reported risk is 89%. So this is the termination, and it is not usually advised, and it is advised just in those cases where the the treatment is not effective and refractive vomiting is there. So now I'm going towards the charts which are present at the end of this presentation. Let us discuss those charts. So before going for termination, we have to assess the mental condition of the patient as well, because those who are poorly tolerated, they can have more chance of postpartum depression, even PTSD, and the mental health is very important. So if anything is not working, we have to do the improvement. I will provide you this highlighted guidelines, so you can study from here as well. I am just narrating to the important points from this guideline. We have to make the multidisciplinary team approach. We have to involve the psychiatrist. We have to involve the dietitian to make a look on nutrition. And then if we are going to provide the parental nutrition, then proper referral to the multidisciplinary team is important. So this is all about that. So all therapeutic measures should have been offered before considering the termination of pregnancy. So only 10% will require that. This is important thing. Okay. What are the long-term effects of nausea and vomiting? There no evidence of significant effects. Okay. What are the long-term effects? Mild to moderate has no effect, but the severe can have anxiety or so small increased risk of certain adverse outcomes in the infant born to women who are having hypertensive gravidorum. With babies can have the anxiety disorder. Baby can have ADHD and autism, which is important. For future pregnancy, we all know that they are at increased risk for recurrence. So now when we're going to start with the chart, I think I've already explained two charts, which are the tools, which tools which are used to diagnose the quantify the problem. I am clear so far. Anything you want to ask so far? Any questions till now? Okay, this was the first chart, which is the pregnancy unique quantification of analysis UK, and I have explained you everything. Like how you are scoring for mild it is 6, for moderate it is 7 to 12, and for severe it is 13 to 15. And here is the health score. And now these are the therapies which are we have discussed already. First line, second line, and third line. Take a print out of this paper and place in front of your eyes, either on of your wall, so that you can look on into it and you can memorize the doses. So this is the visual risk summary. So among so much babies, only this baby, this dark purple baby will be affected with the orofacial defect. If we are going to start with the ondenseron. So the risk is 11 per 10,000, which is very rare. So if the patient is not affected, then the risk is 11 per 10,000, and if the patient is exposed to ondenseron, the risk is 14 per 10,000. And this is also an important exam question as well. So always look at the end of the guideline. You have a lot of things that can be given, that can be asked from the guideline. So now they have given you the summary for the general practitioners. For the general practitioners, why is the active millimeter nausea and vomiting in pregnancy is important? They should know the importance and how the pharmacological treatment should be started. They should identify the risk factors, the onset of symptoms, and what are the prior history, and what has been done with the midwife so far. So we all know that prior to representation towards the GP, they have their midwife, and this midwife is scoring their symptoms in the charts. So what are the practical points? Some other validated patient symptoms that should be like asked. Then comes the antihistamines, which are the phenothiazines, and we all know that doxylamine, it should be prescribed by the GP. And in the in the severe cases, severe diseases, multiple antibiotics can be can be given together. Ketonuria, it should not be used as an indicator for dehydration. And secondary care guidelines should be given uh, that when the patient should be referred for inpatient management. Okay, and the full mental and physical assessment should be there. So here is the initial assessment now. The patient has been initially assessed and now the severity has been diagnosed and it has been scored by the PUK. Like the score is forced that the score is between 3 to 12. The score is 10 out of 15 and this is the way to the patient. So what will the management here? Management in the community. Now the GP is managing this patient. So you have to memorize these three steps. Okay. This is the ambulatory management. This is the management in the community. If the patient is on antibiotic therapy, we have to reassure about the recommendations. We have to support. We have to encourage our hydration. We have to offer the dietary advice. So she should eat little and she should have to prevent an empty stomach. Okay. Consider the use of laxatives. We have to give the proton pump inhibitors like the patient who are H2 receptor blockers. And then comes the mental health assessment. So once the patient is like been assessed, now we have to call her after 24 hours because it is for validity is for 24 hours. Patient is reassessed in 24 to 72 hours and now she is improving. She will be back into the community. There is no need to refer her to other services. But there is minimal or no improvement. Then we have to start one either the second or third antibiotic, as you can see. So it is called up titrating. So we have to do when up titrating, we have to add drugs as opposed to replacing them. Many women may require more than one antibiotic, and so we have to refer for the inpatient management if the red flag signs are there. So what are the red flag signs? We have to know that. We have to memorize these red flag signs. Um, Wait a minute. Sorry for inconvenience. I just yes, these are the red flag signs. Any Q score with any complication like severe dehydration or UTI, inability to tolerate oral fluids, unresponsive to outpatient treatment, clinical dehydration, weight loss, confirmed or suspected comorbidities like diabetes or UTI, comorbidity and unable to take medications in these conditions, and concerned mental health. So these are the red flag signs. So if the patient is not improving and develop any red flag signs, then we will refer to her for inpatient. But if there is no such red flag signs or any QK score, here you can see QK score of more than 30, 13. Here the score is 3 to 12. So this is the question. This side of the guideline is question. This is one question and this is one question. And now you will go and solve the question and you will find it very easy. So here the score is more than 13, but there are no complications and patient is unable to tolerate the oral medications and now we are giving her the ambulatory services. And what are the ambulatory services? I have already explained you. And if any red flag sign, any PUK score, if the score is 3, but the complication is there, you have to refer for the inpatient management. Okay, now comes the management of nausea and vomiting in general practice. This is the checklist that is being provided to the midwife, and here she will do this tick in the box, and she will assess and this will help the GP to identify the problem. And here you can see the whole details of observations have been given, the whole signs of dehydration methods. This is the checklist that has been provided to the GP so that they can certify the patient. So here you can see the urine dipstick, the urea electrolyte, and food blood count and blood glucose. These are the initial testing. Then comes the diagnosis, and the PUK score is already given here. So here they will take the diagnosis whether the patient is going towards the hyperemesis gravidorum or not. And here comes the management again. We have to do the community medicine, community care, and then the ambulatory care, and then the inpatient care. So these are the antiemetics. So antiemetics, I have explained to you that how you are going to provide antiemetics. Up titration is very important. Okay. So initially select one line. First line antiemetics. Use the combination of drugs in the women who do not respond to a single antiemetic. So women are titrating add drugs as opposed to replacing them. Different classes of drugs may have synergetic effects. So we can try first with the second or first with the third even. So and some women will require the combination even 3 plus antiemetics to the control of symptoms. And for all patients, you have to consider histamine type 2 receptors, receptor blockers, then thiamine supplementation, laxatives, and venous thrombolytic risk assessment. Okay, VTE risk assessment should be done for all the patients. And then comes the postpartum planning and the future pregnancy and signposting. And patients with severe hyperemesis gravidorum are at the risk of post-traumatic stress disorder. And for that, it is required we have to refer them to the appropriate services. Okay, these are one, two, three, and four. These are the four services which is the Pregnancy Sickness Code, Her Foundation, UK Terrology Information Services, and Best Use of Medicine in Pregnancy. So these are the services that have been used for the referral for these patients. Okay. In the future pregnancy, early use of lifestyle modification should be explained. Preemptive use of doxylamine and pyridoxine can be used to reduce the severity of disease in subsequent pregnancy. So you can, if the patient is not responding to 10 by 10 dose, you can increase up to 20 by 20 dose. Now, the management of nausea and vomiting and hyperemesis in the ambulatory care. Now, you can see the difference. In the previous chart, you can find a difference here. We have four tests in the previous chart. The community care, urine lift test, urine electrolyte, for blood count, blood glucose. But here, these are the two initial tests. Additional tests are being like patient will be tested for amylase and for venous blood gases as well. And detailed examination should be there. Here we have to assess the mental status as well, and we have to tick all these boxes. And here you can see the possible drug cause, infective symptoms. So for the ambulatory, this is the chart and this is a tick chart which is used for ambulatory care. So once the patient is been referred for the ambulatory care, we have to do these checklists and we have to perform these all tests. So this is an important. All every point of the guideline is given in the last few charts. So don't forget to take the printouts of these charts and to memorize these charts by heart. Again, you have to quantify the symptom by QT scoring. And here you can see for ambulatory one, QT scoring 3 to 12, but no red sign, no red flag signs. We have given the IV fluids, and now we are going to decide the patient. We have to do the uptitrating and anti-emetic therapy. Tick the box. We have explained the oral hydration. Tick the box. If she is able to maintain the oral hydration, or if she is if she is having no mental disorder, if she is not having epilepsy, and she can take her oral hydration very well at home, and she is very well educated, then you can take this box. Offer the dietary advice, and we have to refer for the perinatal health services wherever required. Now we have to start this patient from here. And the score is 3 to 12, and there are no red flag signs. But if the score is more than 13, there is no complication. Patient is not able to tolerate oral intake, and now we are sending her for ambulatory services. We have to take IV9. We have to take the relevant blood test. I explained earlier. We have to give her the ideal solution, which is 0.9% saline with 20 millimoles of KCl. Then thiamine supplementation, which is either in the form of Febrinix, which will this vial will be entered into the fluid that has been given to her. And now we have to stratify this patient from here. This center point is important. We have to reassess this patient. If the patient is improved from this therapy worked on her, patient is improved, we will go and decide this patient here. But if this patient is reassessed and any future COVID complication, again, we have to check all these risks, and here we have to go with the inpatient management plus refer to these services as well. So these services they will come up and they will take care of this patient, and the admission of this patient will be decided. And again, we have to provide them histamine blocker, thiamine supplementation, laxatives, and venous thromboembolism risk assessment. Then comes the emergency department management. Here you can see this is a checklist. The patient, this is the checklist that is being referred from the GP. Uh, check everything from here, ask the history, see the signs and symptoms, initial recordings, and then neurological signs are seen. Then during this stage, during electrolytes, everything is been done. Mm. And then you can see here, mental status is given in the separate box. So mental status is important. Then future system is been used, and here again, the patient either will be retained in the ambulatory, then or it will be referred to the inpatient treatment. Okay, so this is the inpatient management here. Now, in the inpatient management, so this is inpatient management. Okay, so now they can even ask you an extended match person. Then in the inpatient patient has been given in the intramuscular IV antibiotic. What next step will you do? The next step is the is the provision of fluids, and this fluid should contain potassium chloride along with the daily monitoring of electrolytes. Then we have to prescribe her thiamine supplementation. Then we have to do the venous thromboembolism prophylaxis, and you have to tell me the score, okay? All of you have to tell me the score. Then prescribe the histamine receptor antagonist. Then mental health assessment plus refer to the mental health services. Then schedule. So these are the points when we have taken the patient as an admitted patient. So this is the assessment. This is all the assessment. You have to memorize all these things. Then comes the ultrasound. Then comes the constipation treatment in the form of laxatives and either anterior or parenteral therapies if the symptoms fail. If the patient is improved and if the patient is discharged, here you can see we have to do the up titrated antibiotic. So whatever she is taking, if she is on first line, we have to start first line with along with the second line. Okay, or we have to increase the dose of first line. So up titrated antibiotic therapy means that either we are increasing the dose of first or we are giving an additional from the second line or we can combining the all three drugs offer the dietary management and then have to provide the contact numbers for the early pregnancy unit that if they have any problem they can have a contact in the early pregnancy unit. Okay, so up titration first line, then not respond, then add the second line, and when up titrating add drugs as opposed to the replacing them. Then always in the post, always assess the patient for the postpartum and for the future pregnancy that these patients are at risk of developing post-traumatic stress disorder, especially those who are having hyperemesis gravidorum. So lifestyle modification should be advised to them and early referral to the perinatal maternal health system should be provided to them. Okay. So these are all the charts. These are screenshot of the chart, and this is the most appropriate IV hydration. Onset, ondansetron available in Pakistan. The dose is 8 milligrams. Then cinnarizine tablet. So these are the charts we have already discussed, and I have added in the presentation. You can take a screenshot of, you can take a printout of these charts, and you have to memorize the charts. So everything that has been given in the guideline is summarized, and the management is given in the end of that. So hydrocortisone, prednisolone, ginger tea should not be given, and it may um, also delay the access to the effective treatment. Thank you so much. Um, I hope my lecture is concise and will help you in solving the questions related to this guideline. This guideline has been recently updated, and I have provided you every possible detail that has been given in this guideline. Thank you so much, and now I will open the house for the questions. All kind of questions will be accepted. So, any questions so far? Any questions? Hope everything is fine and your preparation is going smooth. If you find any difficulty, you should not forget to ask me, and we should wait